A 55-year-old man comes to the physician with a 2-month history of severe cough and shortness of breath. He has a 35-pack year smoking history. Physical examination finds tenderness and crepitus over the patient's chest. Laboratory tests show a serum calcium level of 12.2 milligrams per deciliter and a serum phosphorus level of 2.7 milligrams per deciliter. Which of the following best explains this serum calcium finding? Choice A, parathyroid hormone secretion. Choice B, rib fracture. Choice C, macrophage activation. Choice D, increased hydroxylase enzyme activity. Or choice E, renal cell malignancy. I'll wait 5 seconds and answer the question. So you have a patient here with respiratory symptoms, long smoking history, and this hypercalcemia. That's usually a bunch of red flags for you to thinking squamous cell carcinoma, which releases PTH-RP into the bloodstream, which will have the same effect as PTH. It will stimulate osteoclasts for bone resorption. You'll get calcium from there. It'll increase renal reabsorption of calcium while also increasing phosphorus excretion. And it will stimulate 1-alpha hydroxylase enzyme to produce activated vitamin D, or calcitriol. So that's why choice D, increased hydroxylase enzyme activity, is the correct answer. Not much else to say here. Pretty straightforward diagnosis in paraneoplastic syndrome that you need to know. I just worded some of the answer choices in a funny way to trip you up, but USMLE likes to do that too. So let's look at the wrong answer choices here. Choice A, parathyroid hormone secretion. You need to know that PTH-RP is not the same thing as PTH. So PTH-RP can be secreted by a number of malignancies, which of course is squamous cell carcinoma, like this patient. It can also be released by renal cell carcinoma. Those are the two you want to know most for USMLE. But like I say, PTH-RP is not the same thing as PTH. They do similar functions, but they are not the same protein. PTH itself can be elevated in like a parathyroid hyperplasia or something. Choice B, rib fracture. So, of course, lung cancer, you can get bone metastases, especially metastases over to the rib. And I also gave you this symptom in the question where I tell you that the patient has crepitus over his chest. So this patient probably has a rib fracture. But if my concern was bone metastasis, you would not have this reduced phosphorus level. That's more emblematic of a PTH or PTH-RP effect. In bone metastases, the phosphorus level can vary, but usually it'll either be normal or high because of released from the affected bone. Choice C, macrophage activation. So activated macrophages in sarcoidosis can produce 1-alpha hydroxylase, which of course ends up having a similar effect to what you see here, because 1-alpha hydroxylase of course leads to activated vitamin D, so you'll have hypervitaminosis D in sarcoidosis. But mainly here, it's based on demographic. You have a 55-year-old man, whereas with sarcoidosis, you tend to think young, maybe 20s to 40s for female, more common in African Americans. And sarcoidosis isn't really associated with smoking. Choice E, renal cell malignancy. Like I already said, PTH-RP can be released by RCC, but I mean, just look at the entire question. Where does it anywhere imply that this patient might have some kind of renal pathology? Most common thing you'll see in questions, if they want to present to you with an RCC that hasn't been diagnosed, it'll be painless hematuria. And it might give you like hypercalcemia symptoms just to help you along. But in this particular case, it's just like, there's no reason for you to pick this answer choice. So bring it back, like I said, squamous cell carcinoma, you want to know the associated PTH-RP release, which can lead to the same effects as PTH. Bone resorption, hypercalcemia, hypophosphatemia, and increased activation of vitamin D. Hope you found this video helpful. I'll see you in the next one.